This recording is Joints Part 2 of 2. It's important to remember that structural classification of joints includes two terms. The first is the main category of the joint, whether it is fibrous, cartilaginous, or synovial. The second term is the subcategory belonging to that particular category. So we have fibrous syndesmoses, fibrous sutures, fibrous sconphoses, cartilaginous synchondroses, cartilaginous symphyses. Synovial joints have 6 subcategories. The names of the subcategories of synovial joints are based upon either their structure or their function. Looking at the first type of synovial joint, the synovial pivot joint occurs between atlas and axis, which you'll remember are the first and second cervical vertebrae in the spine. This is because atlas is going to pivot around the dens of axis. There is another example of a pivot joint between radius and ulna that allows you to pivot your forearm in this direction. It actually pivots not only around the ulna, it pivots at the capitulum, at the distal aspect of the humerus. Another type of synovial joint is the synovial hinge joint. A classic example of a synovial hinge is the elbow, where the trochlear notch of the ulna rides around the trochlea of the humerus. A hinge joint is easy to understand if you look at a hinge in a door. Condyloid joints, also known as ellipsoid joints, and yes, you should know both terms, are often found between the metacarpophalangeal joints that make up your knuckles. A good example of an ellipsoid or condyloid joint is also found at the distal radius, where it forms a joint with scaphoid. That is what this particular picture mentions, between radius and the carpal bones of the wrist. The radius mostly articulates with scaphoid. Another type of synovial joint is a synovial saddle joint. The synovial saddle joint occurs at the trapezium and the first metacarpal of the hand and allows for opposition and reposition. Looking at this picture of a synovial saddle joint, you can see the saddle portion or seat is here, and that is made up by the trapezium, whereas the way the first metacarpal sits on trapezium, that forms the rider for this saddle joint. Another type of synovial joint is the synovial plane or synovial gliding joint. A synovial plane joint or synovial gliding joint usually occurs between bones that have relatively flat surfaces, as is the case with the tarsal bones. There are some synovial gliding joints between the carpals as well. Ball and socket joints are literally where the head of the humerus or the femur fits into the socket formed by the glenoid cavity or acetabulum, respectively. Ball and socket joints allow for the most motion to occur out of all of the synovial joints. In this picture, they show the ball and socket joint at the hip. To go over some body movements quickly, flexion is decreasing the angle between bones at a joint. Extension is increasing the angle between bones at a joint or articulation. However, it can include things that are not so obvious. This is actually shoulder flexion. Shoulder extension is coming back to anatomic position. Anything that takes me beyond anatomic position, an easy way to demonstrate that is flexion of the neck, extension of the neck, hyperextension of the neck. Again, anything that takes the body beyond anatomic position is considered hyperextension. Lateral flexion is simply flexing laterally along the frontal plane. Abduction means taking things away from midline. Adduction, think of adding together towards the midline to the point where things can cross. Rotation is moving a bone around its long axis. Supination is easy to demonstrate if you remember anatomic position. Hands are at the sides, palms are facing forward. This is supination. It actually describes the radius and ulna and how they're positioned together. Pronation, if I rotate this way, that would be pronation. So supination, pronation. You can also think of holding a bowl of soup. Supination holds the bowl of soup. My thumbs are out laterally. Pronation, I can't hold the bowl of soup. Supination, pronation. With inversion versus eversion, I took my shoes off so I could show you this. Inversion is the sole of the foot turning in medially so that the ankle goes out laterally. Inversion has to do with the sole of the foot coming in medially. Eversion is harder to do. It's where the sole of the foot goes out laterally. The most common type of ankle sprain is an inversion ankle sprain. People will be walking along, or a person might be walking along, and all of a sudden he turns his ankle, and that's going to most commonly be an inversion ankle sprain. While we're here, let's do dorsiflexion, bringing the toes up towards your face. Plantar flexion, planting the toes into the ground. So I have dorsiflexion and plantar flexion. Dorsiflexion, plantar flexion. Rotation can be medial or lateral. Here's medial rotation or lateral rotation. I can also do medial rotation this way, lateral rotation this way. Now, oftentimes physical therapists will say internal rotation versus external rotation. We have much more internal rotation at the shoulder than we have external rotation. We have rotation at the hip. There's even a little bit of rotation that occurs between the tibia and the femur. When you extend your leg in walking, the tibia rotates externally about 5 degrees and then rotates inward when the knee is taken out of extension. Opposition is putting opposite digits together. The saddle joint, which is the trapezium and the first metacarpal, is designed to allow for opposition and reposition. Opposition, reposition, opposition, reposition. So opposite digits coming together, reposition, putting them back. Lateral excursion is best demonstrated at the temporomandibular joint, moving the jaw from side to side. Depression and elevation. Elevation is elevating a body part or body parts, and depression is moving them downward. So elevation, depression. Protraction versus retraction. I can also protract my mandible and retract it. Protract, retract, protract, retract. I can protract my neck, retract, protract, retract, protract, retract. Here are some pictures of body motions. Practice these. Tell people what you're doing. You can protract your shoulders and retract your shoulders. Protract, retract, protract, retract, protract, retract. You can just tell them you're practicing protraction and retraction. In order to further understand the joints that occur within the vertebral column, we need to take a closer look at some of the parts of the vertebra that we did not yet learn. If you look at the lower right-hand side of your screen, you will notice a picture of a vertebra. This happens to be a lumbar vertebra. You can see the vertebral body is the thickened portion here. You can see the spinous process. We also notice the transverse processes on either side. Some of the pieces we've not yet mentioned that are a part of the vertebrae are the articular processes. Remember, the word articular means pertaining to a joint. A process is just something that sticks out. We have on both the right and left-hand sides of the vertebra superior articular processes, as well as below inferior articular processes. These processes, both the superior and inferior processes, are going to form joints known as facet joints. The inferior articular process of the vertebra above, which is right here, will form a joint or articulation with the superior articular process from the vertebra below. These are plane joints that allow limited motion. The cervical and lumbar regions of the vertebral column have the greatest range of motion. Going back to the joint form between atlas and axis, which is known as the atlantoaxial joint, we see that atlas is a ring, and looking from superior to inferior, we can see the dens of axis here. And we know that atlas is held in place on axis by a ligament. The atlantoaxial joint between atlas and axis allows rotation to occur that forms a no motion. So here's rotation at the atlantoaxial joint. 50% of rotation occurs between atlas and axis. The rest of it is taken up by the rest of the cervical spine, which will join in the motion to add for an additional range of motion. If someone has a cervical fusion that causes the 3rd through 7th cervical vertebrae to be fused, perhaps the person was in a car accident, that individual will have 50% of rotation between atlas and axis, but most likely will start turning his torso to have additional range of motion to look back if something is oncoming. The atlanto-occipital joint is the joint between the occipital condyles of occiput and the superior articular facets of atlas, which you can see in this picture. The atlanto-occipital joint allows for 50% of nodding, which is a yes motion, and then beyond that 50%, the rest of the cervical spine will kick in for additional flexion and extension, which technically this is flexion extension. From now on, we're going to use the specific names of the joints. Remember, there's structural classification according to what holds it together, functional classification according to how much it can move, and the actual name of the joint. If you were to meet me on the street and said, "Hey, Dr. C, that's my name. I am classified as a woman, a living human being. My name is Dr. C." This is technically classified as a synovial condyloid joint. However, its name is the atlanto-occipital joint. You really need to learn these names. They will be on tests, and not just the lecture tests, but also on your lab exam. So it's really important for you to learn these terms. If there is something confusing, as is on this slide where it says that these are synovial condyloid joints, and then further down it says they're socket type joints, these are not ball and socket joints. These are synovial condyloid joints. I would not ask you a question on something that was potentially confusing like this. The temporomandibular joint occurs between the mandibular fossa of the temporal bone and the mandibular condyle of the mandible. The structure of this joint allows for elevation and depression, as well as lateral excursion and protraction and retraction of the lower jaw. Sometimes people experience pain at this joint and are diagnosed with TMJ. TMJ stands for temporomandibular joint. Everybody has TMJ, but TMJ joint pain is different. The shoulder joint, which at this point we are now referring to as the glenohumeral joint, is a ball and socket joint. So it is a synovial ball and socket joint that occurs between the head of the humerus and the glenoid cavity of the scapula. The glenohumeral joint has the largest range of motion of any joint in the body. It has a very poor structural support though, and the glenoid cavity is a shallow cavity for the socket, so it's easy to dislocate the glenohumeral joint because there's not much structural support holding the joint together, and because it's got a very shallow socket. The socket is somewhat deepened by a lip of connective tissue that forms a structure called the glenoid labrum. The glenoid labrum helps to deepen the socket a little bit more to help hold the shoulder in place. The elbow joint consists of both a humero-ulnar joint and a humero-radial joint. Remember that the ulna articulates with the trochlea of the humerus, and the radius articulates with the capitulum of the humerus. Those would be important things to know. When we look at the articular capsule of the elbow, you can see that there are different ligaments that help hold the elbow joint together, such as the ulnar collateral ligament and the annular ligament, which runs around the radius. This is part of the annular ligament here. The iliofemoral joint, your hip joint, is a multi-axial, which means it moves in different directions, different axes, multi-axial synovial ball and socket joint. Remember, always stick the word synovial if you're using structural terms. This iliofemoral joint is formed by the head of the femur and the acetabulum of the coxal bone. It does have a limited range of motion because the acetabular labrum deepens the socket, and the socket of the acetabulum itself is much deeper than the glenoid cavity. There are also more ligamentous and muscular structures that help to hold the iliofemoral joint in place. There is a ligament that goes between the femoral head and the acetabulum. That is the ligamentum teres. It is intracapsular. That means within the joint capsule. It's inside the joint itself. And it also houses an artery that is really important in supplying oxygen and nutrients to the head of the femur. Broken hips, unfortunately, tend to be a common injury in elderly people, especially those who have osteoporosis. Usually what occurs is the neck of the femur fractures that causes a fall to result after the fracture has occurred. Sometimes falling will cause the fracture, but more times than not, they're realizing that the neck of the femur fractures, which causes the person to fall. The disruption of blood to the bone can cause the bone and the articular cartilage to die, and most always requires some form of surgery to heal the broken area. There are different ways that surgery can occur. Sometimes they will simply insert screws depending on how bad the fracture is. That is an internal fixation. Sometimes they use a hip compression screw, where a screw actually helps to draw the parts of the bone together to compress them tightly so they heal better. Sometimes a partial hip replacement will occur, where a replacement femur head will be hammered down into the shaft of the femur. And sometimes a total hip replacement is required, where the capsule of the acetabulum has to be replaced, that socket for the head of the femur, as well as the artificial femur head will have to be replaced, and that is a total hip replacement. With fractures, especially in the elderly, this can sometimes result in those individuals requiring prolonged bed rest. If they're immobile for too long, they can develop secondary complications such as pneumonia, bed sores, blood clots, or deep vein thrombosis. The knee joint consists of 3 articulations. Therefore, we still refer to it as the knee joint. However, you should know these names. The femoropatellar joint is the joint between the femur and the patella. The medial tibiofemoral joint occurs between the medial aspect of the tibia and the femur. The lateral tibial femoral joint occurs between the lateral aspect of the tibia and the femur. You'll notice that on the superior aspect of the tibia, where I'm drawing yellow highlights, is where we see the menisci of the knee that you remember are fibrocartilaginous discs. The lateral meniscus is smaller than the medial meniscus. We weight bear on the medial aspect of the tibia. The knee joint is the largest joint in the body. It is a modified hinge joint that allows for flexion and extension of the leg. Also associated with the knee joint is the patellar ligament, which runs from the patella to the tibial tuberosity. The tibial collateral ligament, also known as the medial collateral ligament, which connects the tibia and the femur. We see the fibular collateral ligament, which joins the femur with the fibula laterally. We see interiorly an anterior cruciate ligament that prevents the knee from going too far forward anteriorly, prevents the tibia from going too far forward anteriorly in relation to the femur. We also see the posterior cruciate ligament, which prevents the tibia from going too far posteriorly in relation to the femur. These cruciate ligaments are so named because interiorly they form a cross, hence the term cruciate, cross-like. Something that's important to understand about the tibial collateral ligament and the fibular collateral ligament is that the tibial collateral ligament or medial collateral ligament actually attaches directly to the medial meniscus on the tibia. The lateral collateral ligament or fibular collateral ligament does not do this. If an athlete receives a powerful blow to the lateral aspect of the leg from behind, that can potentially cause damage to the anterior cruciate ligament, as well as to the medial collateral ligament or tibial collateral ligament, and to the medial meniscus, because remember, these structures are attached to one another. The medial meniscus and medial collateral ligament or tibial collateral ligament are attached to one another. This injury is known as a terrible triad knee injury. 3 structures are involved: the anterior cruciate ligament, medial collateral ligament, medial meniscus. You should know that medial collateral ligament and tibial collateral ligament are the same thing, and you should also know that the fibular collateral ligament and lateral collateral ligament are the same thing. However, the lateral collateral ligament does not attach to the lateral meniscus. The only ligament that attaches to the medial meniscus, or either one of them, but in this case the medial meniscus, is the medial collateral ligament. Again, that is called the terrible triad. For anyone who is familiar with football, this type of injury would call for a foul known as clipping. The ankle joint also consists of several joints, including the talocrural joint between talus and the distal ends of tibia and fibula. It is a uniaxial joint which allows for dorsiflexion and plantar flexion. There is also a subtalar joint found between talus and calcaneus. With the ankle joint, we can see the deltoid ligament, which is a very, very strong ligament that looks like the Greek letter delta. This ligament prevents eversion of the ankle. On the lateral aspect of the ankle, there is a smaller calcaneofibular ligament going between calcaneus and the lateral malleolus of the fibula. This calcaneofibular ligament is weaker and therefore allows the sole of the foot to turn medially with the event of an inversion ankle sprain. There are also anterior and posterior talofibular ligaments going from talus to the fibula. And we have posterior and anterior tibiofibular ligaments. The main one to know on the ankle joint is the deltoid ligament. This prevents excessive eversion of the ankle. A Pott's fracture is a colloquial term for a fracture of the distal fibula and the distal portion or medial malleolus of the tibia. Because the deltoid ligament is very strong, it rarely tears, and it's more likely that those portions of bone will fracture. Usually Pott's fractures are due to severe abduction and eversive forces of the ankle. Any sprain is a stretching or tearing of supporting ligaments within a joint. If excessive inversion occurs at the ankle, that can cause damage to the lateral ligaments, and usually the anterior talofibular and calcaneofibular ligaments are going to be the ones most affected by an ankle spray. Remember that inversion ankle sprains or ankle injuries are much more common than eversion ankle injuries.